My name is Raquel Romero. I am so glad to see you, and I hope you and your family are doing well. I'm a physician by training, and I want to be the facilitator for the ECHO session today. We have a lot of information to cover, but before we begin, we have some recommendations from our UT ECHO IT about the audio connection. Please stay muted only if you are speaking. You can use the star 6 on your phone if you are calling in, or if you're using the computer, you can use the microphone icon in the bottom left of your screen. And we encourage you to share your comments, perspectives, and questions using the chat box. If you have any situation, any question or problem with the connection, please add your comments in the chat box. You can also send a private message to the UT ECHO IT. And please remember that no personal health information is allowed within discussing cases and scenarios. We would love to see everyone's faces. If you are able and comfortable, please join us by video, especially in the discussion part of the session. I would like to go ahead and do the introductions, and we have a large group, so I would like to ask you if you please add your name, your title, the organization, your contact information, and the institution organization that you work and represent. This is for our attendance records. Health Confianza is a county-wide collaboration to improve access and the uses of the COVID-19 health information in the service in Bejar County. With that, and before we get started, I would like to use this space to introduce the COVID-19 Health Literacy ECHO team, and I would like to start with our lead specialist and moderator, Dr. Bergen.
Hi, everyone. I'm Ruth Berggren. I'm an infectious disease specialist at UT Health Science Center, and I am a member of the Health Confianza team. And I would like to have 1 second to remind you that if you get a survey about our ECHO, we would really deeply appreciate it if you could please fill it out. It is a requirement of reporting for the funding that we have for this program. Thank you.
Thank you very much, Dr. Bergen. And you're going to receive the information in the chat. ECHO IT will start presenting those links in the chat during the session today, but your feedback is very, very important for us. I would like to continue with the introductions with Dr. Markel, panelist today.
Hi, good afternoon. I'm Dr. Elizabeth Markels. I'm also an infectious disease adult physician. I'm also an active duty Army physician, and I'm at Brooke Army Medical Center.
Thank you very much, Dr. Markels. And we have Dr. Feivelkorn, panelist too.
Hi, I'm Dr. Feivelkorn. I am a pathologist and medical microbiology subspecialist, and I am the director of the virology laboratory at University Hospital. And I also sign out the COVID variant sequencing at UT Health San Antonio. Thank
you very much. We also have didactics, Dr. Ponce. We have a pre-record presentation. We want to see that later. And also we have as a panelist, Dr. Pearson. I'm not sure if he joined already our session, but those are part of our hub team today.
I think Dr. Pearson may be joining us later. She was having some connectivity issue. Oh, there she is. Dr. Pearson, are you able to unmute? Not hearing her right away. We hope that Dr. Pearson will resolve her audio issues but when we get to the interactive part of our session. But there is pediatric representation today, which is important, and we're delighted.
Excited to be here. Thank you so much for having me.
All right. Good to see you.
Thank you. Thank you very much. And if you have some issues with the connection of video, please send a message to the ECHO IT. Well, thank you very much. And I have some updates. These sessions are possible because of you, because your interest and your support and your feedback is very, very important for us. A quick reminder, toward the end of the session, our team will send a link for an evaluation. Please take a moment and complete this evaluation. It is so important for us. And we always want to invite practices, providers, and organizations to be part of this learning community. If you know, I'm seeing the picture, Dr. Pearson. If you know somebody that can join the sessions, please reach out to us. We would like to provide some information about the ECHO and how they can be part of this learning community. ECHO stands for Extended Extension for Community Health Care Outcomes is a model of learning opportunity and telementorship. It's a model that brings the knowledge when is needed, where is needed, and build capacity for delivering the best practice. Our core elements are didactic, case-based discussion, and dynamic conversation. For all those, we invite you to be part of this learning opportunity. The case presentation is an important component of the ECHO model, and we might invite you to submit the clinical or non-clinical cases. And for those that already present a case, we invite you to consider to present a follow-up of the cases. We would like to learn from your experience while taking care of the patients. ECHO IT will share instructions in the case submission in the chat. And please check our website to learn more about the ECHO model and then ongoing ECHO programs. This ECHO series offers CME, CNE, and ETIS continuing medical education. To obtain those credits, the information is going to be in the chat, but I can tell you the activity code is 100923889. Finally, I would like to mention that ECHO is all teach, all learn environment. So we encourage to share your experience, questions, and insights in our conversation. With no more from my end, I would like to continue with didactics. We have Dr. Ponce kindly pre-record the session, and I would like to ask UT ECHO IT, please share the didactics. Thank you so much.
Hi, everybody. I'm Phil Ponce. I'm one of the faculty members here at UT Health San Antonio. My day job is taking care of immunocompromised hosts, transplant recipients, or people living with HIV. But like many of you, I've spent the past few years doing a lot of work around COVID. So thanks for the opportunity to give you some quick COVID updates at almost the 3-year mark. This was actually the title that I wanted to use, but it did not fit on that first slide. It's been a long road for most of us. You know, it seems like a lifetime ago, you know, we first started getting reports of this undiagnosed pneumonia in Hubei, China. And look at where we are now. I will say that we have had a lot of incredible progress over the past 3 years. So for hospitalized patients, we now have the IV antiviral remdesivir. We also know that we can use immunomodulators to attenuate a lot of the most severe effects of the COVID illness using dexamethasone or baricitinib, or if people are have really severe disease, using tocilizumab or sarilumab to block IL-6. We also know that in hospitalized patients who are not in the ICU, COVID is a prothrombotic state, and so it's helpful to give those people increased doses of anticoagulation, put them on therapeutic as opposed to prophylactic anticoagulation. We also have had the luxury of having monoclonals both for preemptive treatment in high-risk people, as well as one monoclonal antibody that we were able to give to immunocompromised hosts who wouldn't mount a vaccine response in order to, again, prevent them from getting the illness. That is changing very rapidly, so that's actually what I'll focus quite a bit of the talk on. Most importantly, and I think what's made the major impact, is that we now have very safe and very effective vaccines. Hopefully everybody in the audience has gotten their bivalent booster and is prepared for what seems to looking to be a pretty bad winter. And then, you know, we also now have the outpatient antiviral Paxlovid. So we'll talk a little bit about its use, specifically when it might not be a good idea to use it in particular patient populations. So if you remember, we've had ongoing circulation of virus with various surges, and what we've seen is this persistent viral evolution. So if you take a virus, you allow for untrammeled transmission, you know, over time, the virus is going to select for the most transmissible versions of itself. And in the setting of ongoing transmission, you also allow for mutations that are going to escape the immune response and eventually maybe escape the effect of antiviral drugs. We haven't seen any mutations that affect the efficacy of antiviral drugs yet, but the immune escape issue has definitely come to the forefront with the Omicron variants. Just to remind you, we had the initial wild type variant, and then we had Alpha, and then we had Delta, and then this was Omicron last winter. And now we're somewhere here. We are dealing with the descendants of Omicron, if you will. The Omicron variant was the most transmissible variant. These descendants of the Omicron lineage are even more transmissible. And then they also have some immune escapability. And so that's why they are currently the predominant circulating strain of COVID. I will say that even though we continue to have surges, you can see how dramatically mortality has improved, especially over the past year. We're still losing about 500 people a day from COVID. So the pandemic is by no means over, but the consequences of it are much less. With all the therapies that we have and the vaccines, people are much less likely to develop moderate to severe illness that would require them to be hospitalized or land them in the ICU. Again, the patient population that seems to be most affected currently are my patient population, people who are on immunosuppressive drugs or have immunosuppressive conditions and cannot mount an effective immune response against the virus. So this is the latest data from the CDC, and what you can see is BA.5, which was the Omicron variant that really has predominated over the past several months, along with another one called BA.4. These are the two that are targeted by the bivalent booster that I mentioned earlier today. Those have been steadily replaced by the BQ1 and the BQ1.1 sublineages. Again, the reason for that is, again, each iteration of the virus becomes more and more transmissible. And then in addition to being very transmissible, BQ1 and BQ1.1 and all of their sublineages have mutations in the spike protein that allow for immune escape. There are different levels of mutations. So my colleague, Dr. Feivelkorn, can talk a little bit more about the mutations and the virology of this a little bit later in the question and answer period. So again, immune evasion is, kind of a jargony phrase that we use, but it basically means that the antibodies that the vaccine response induces do not work well to neutralize the virus. So you get exposed to the virus, the antibodies don't work as well, and so the virus is able to attach to ACE2 receptors and then make you sick. And again, in this setting, it gives the virus a competitive advantage in transmission. So what that means is, we will all probably need another booster at some point, and we will probably continue to require boosters over time. More and more, it's looking like COVID is going to be like the flu, where we need basically an annual or semi-annual booster in order to keep up with the viral evolution and try to stay ahead of it. The implications, though, are also that our monoclonal antibodies are no longer going to be effective. So Evusheld, which is a combination of two antibodies, tixagevimab, tilgevimab, is no longer effective. It had some efficacy against the BA.4 and 5. However, with the BQ1 and BQ1.1 strains, it is no longer effective. This was a major tool in our armamentarium to protect immunocompromised hosts who will, just because of the status of their immune system, will not mount a very effective immune response. And so without this in an armamentarium, it means that the immunocompromised need to be extra diligent about risk-reducing behaviors. The authorization, the emergency use authorization from the FDA for this is still active, just because there are no acceptable alternatives that have been developed as yet. And there may be some partial protection against, at least against some of the earlier Omicron strains, so that may have some benefit for the patients. So patients can still receive this. But what that means is that with immunocompromised patients, if when they become ill, they need to be started on preemptive therapy as quickly as possible, because they're less well protected, they're more likely to develop symptomatic infection. In terms of therapeutics, so the monoclonal that we had been using, bebtelovimab, this was again for preemptive therapy of unhospitalized patients in order to prevent them from developing moderate to severe disease that would lead them to the hospital. This had been effective against BA4 and 5, but it is no longer effective against BQ1 and BQ1.1. So given that, it actually no longer has emergency use authorization in the US. So again, if you have somebody who develops infection with BQ1 and BQ1.1, you have to think about preemptive antiviral therapy as opposed to monoclonal antibody therapy. I will say there is now a lot of ongoing work until new monoclonal antibodies can be developed in using convalescent plasma. If you remember the first year of the epidemic, there was a lot of excitement about using convalescent plasma as a way to help hospitalized patients. And once again, it looks like we are going to be using convalescent plasma to a certain extent because many people who've previously had Omicron infections with any of the prior Omicron variants or who've gotten the bivalent booster, they do seem to develop some antibodies that are effective against the BQ1 and the BQ1.1 subvariants, and so there may be some efficacy there and some rationale for using this in the high-risk population when they become infected. So in terms of trying to get the high-titer convalescent plasma, you have to get it under one of three mechanisms. So there is an emergency use authorization, but this is only for a very limited patient population. If you do it under the EUA, you don't have to report it to the FDA. You have to maintain records of any patients who you treat. You have to investigate any adverse reactions after transfusions. And if there's any deaths, you definitely have to report to the FDA. The FDA is really recommending that the use of high-titer convalescent plasma go through the clinical trial process. So we actually develop some data on efficacy. There are limited centers that are participating in some of these clinical trials, and so that may not be feasible, especially in the Central and South Texas area where I'm located. And then you can try to use it under the traditional IND pathway. So investigational new drug pathway, that means you basically ask the FDA for permission to use the medication in a specific patient for a specific indication. If you've done this process before, it's a lot of paperwork, but it may be worth going through depending on the patient and if you cannot get the high-titer convalescent plasma under other means. In terms of the EUA, right now the EUA really says that high-titer convalescent plasma should only be used for those who have an immunosuppressive disease or who have immunosuppressive treatment. Why is that? That seemed a little bit unfair. And a lot of this is because we actually have data on the use of convalescent plasma in immunocompetent hospitalized adults. Again, this was the first year of the pandemic, and so this was a hot topic, and so a lot of research time and effort went into looking at convalescent plasma. So we have data from 3 clinical trials: Recovery, Conquer-1, and REMAP-CAP, and it does not look like there's benefit to giving convalescent plasma to folks who are immunocompetent and who are hospitalized. There has been some conflicting data in non-hospitalized immunocompetent adults. And so again, this is where the clinical trial pathway becomes very important, where if you can register these people, when they are diagnosed and have mild illness, perhaps giving them the high-titer convalescent plasma is going to be equivalent to giving them a monoclonal antibody and prevent progression of disease. So hopefully, we see more of these clinical trials popping up in various areas. If you want to review some of the data on this, the NIH guidelines have a section with a great table that has all of the specific literature on this topic. So in whom should you consider the IND pathway? Again, the EUA pathway is really for the immunocompromised folks. But with the IND pathway, you can think about it in immunocompetent people who aren't hospitalized, who have mild or moderate disease. They're not yet hospitalized or hypoxic. but they have a risk factors for progression to severe disease. With most of these patients, you should be able to give them the antiviral drugs, which I'll talk about a little bit, as their preemptive therapy instead of doing the convalescent plasma. But if there's a contraindication to the use of antiviral drugs, then this is the patient population in whom you may want to consider doing the individual request for that patient. When you have somebody who is immunocompetent and not hospitalized, the go-to in terms of preemptive therapy has been Paxlovid. Paxlovid is a combination of antivirals. One is nirmatrelvir. This actually has activity against the SARS-CoV-2 virus. And then that's coupled with an old HIV medication called ritonavir. Ritonavir is really there as a booster. It's one of the most potent inhibitors of the cytochrome P450 enzyme pathway. And so it has a ton of drug-drug interactions. And so depending on what medications your patient is on, you may or may not be able to use it without there being consequences. In transplant patients, it's very difficult for us to use it because there is an interaction between ritonavir and tacrolimus, and that inhibition of the CYP3A4 enzyme will lead to incredibly high levels of PROGRAF, which can be neurotoxic and nephrotoxic. So we've had patients hospitalized, not so much because of COVID, but because they received Paxlovid and then developed PROGRAF toxicity. So again, if you're prescribing this or anybody, really just check the drug-drug interactions to make sure that there aren't going to be those kinds of consequences to using the medication in your patient. So if you can't get Paxlovid, again, this is where you can think about the convalescent plasma piece, but there's a couple other things you can consider. One is giving them remdesivir. So there was a clinical trial called Pine Tree that was published, I guess, a year and a half ago now. And this said that when you have people who have mild disease, newly diagnosed with COVID, and you give them remdesivir for 3 days, 200 milligrams first day, 100 milligrams on day 2 and 3, this prevents them from progressing to severe enough disease that would lead them to be hypoxic or require hospitalization. Remdesivir, unfortunately, is only intravenous. So this can be logistically challenging if your hospitals are like our hospitals. They're currently overwhelmed with a surge of non-COVID respiratory viruses. So it's very difficult to get people directly admitted for remdesivir therapy. So you either have to have an outpatient program in place for these patients to get the IV infusion, or you have to use a hospital at home program where somebody will go out to their home and actually administer the remdesivir for them. There is another antiviral called molnupiravir. I personally would only use this if there are no other options. So remdesivir, Paxlovid, the monoclonals, which we're extrapolating to convalescent plasma, reduced the risk of progression to severe disease by over 90%, whereas molnupiravir really only reduced the risk of progression by about 30%. So it is much less effective than these other options. There's also the possibility that it will lead to increased evolution, mutation of the virus, and then get us into even more trouble pretty quickly. So use of molnupiravir overall has been pretty low for those reasons. And again, I would only use it if you really cannot get one of these other options for your patient. So that's dealing with new infections and patients who are actually diagnosed with COVID. And then what we're seeing more and more is that once people recover from acute COVID, many of them are dealing with the post-acute sequelae of COVID, or PASC is the new jargony abbreviation that people are using. In the public sphere, this is called long COVID or long haul COVID. And so the CDC estimates that just about all Americans have had COVID infection at this point. They may not have been symptomatic, but given the transmissibility of the Omicron variant and its subvariants, more than likely most people in the US have been exposed. And unfortunately, about 30% of people who get COVID infection develop protracted symptoms after recovery. what symptoms they get, the severity of the symptoms is very heterogeneous. We don't really have a good way of predicting who's going to develop these complications after the acute phase has passed, or what kind of symptomatology that they're going to have. But it does look like the risk of developing these long-term sequelae of COVID infection, it rises with every subsequent infection. So again, this is one of the reasons you have to keep up to date with the booster. Any potential advantage that you have to prevent infection, you should really utilize it, because again, in the background, there's the specter of the post-acute sequelae. It's estimated that the possible economic impact of long COVID is going to be something like $3.7 trillion. This is about equivalent to what we saw with the Great Recession a couple of years ago. That figure comes from Larry Summers and his colleagues at the Harvard Department of Economics. I'm inclined to believe it just because Larry Summers was one of the few economists who actually predicted that we would see a hyperinflationary response with all of the stimulus money that was out there. So, I think he knows what he's talking about. Right now, there are a lot of studies underway, but we don't really have any clear treatments for long COVID apart from controlling symptomatology. We don't really even know the mechanism of long COVID. Is it an abnormal persistent immune response? Is it that some people have a reservoir of virus and never fully clear it? These are all hypotheses. We just don't know really what we need to target in order to get people feeling better. So again, vaccination does reduce the risk of getting the post-acute sequelae of COVID. So hopefully the vaccination prevents you from getting sick at all. But if you do become sick, you're less likely to develop long-haul COVID if you've gotten the vaccine. And there's some excitement that using these antiviral drugs, so remdesivir or Paxlovid, in the patients who have long-haul COVID may attenuate the symptoms and hopefully stop the process. Again, this is based on the hypothesis that maybe some of these people with long COVID have some reservoir where there's ongoing viral replication in their system, and so the antivirals will stop that and allow these people to recover. Again, a lot of this data is very preliminary. It's not something I would jump to doing in clinic just yet if you're seeing somebody with long COVID, but it's definitely something to watch over the next few months as we get more and more data. Again, this is the other study for long COVID. I just wanted to point these out to you. So if you are in an area where you can support clinical trials, please refer patients. Rapid enrollment in clinical trials has really been what's led to us having all of these tools in our armamentarium to reduce the morbidity and mortality of COVID. We've come a long way in 3 years because of this. So the other thing I just wanted to mention before I conclude is, we are seeing syndemic respiratory viruses. So we have reopened, people are not really masking, they're not really doing the hand hygiene as well as they probably should, they're no longer social distancing, kids are back in school, especially young kids will bring these viruses back into the home. And so what we've seen is an early and pretty dramatic rise in the number of cases of both RSV and influenza. We're seeing numbers that we typically see midwinter at the peak of respiratory virus season. We're seeing that very, very early. You may have heard some of the news that many children's hospitals were overwhelmed just because of the number of cases of RSV. That's getting slightly better, but we're not out of the woods yet. And again, we are also seeing quite a bit of flu. So everything old is new again. So, I would strongly encourage you to encourage your patients to get the influenza vaccine, to be up to date on their COVID boosters. But again, a lot of the behavioral stuff that we were doing during the initial phase of the pandemic, it's probably worth going back to over the next several months just to try to attenuate all of the respiratory viruses and complications as such that we might see. With that, I will conclude. I thank you for your time and attention. Sorry I couldn't be there in person, but my colleagues will be sure to give you good data, good input in the question and answer period. Thanks again.
All right, as always, Dr. Phil Ponce gives us an excellent update, and there have been a lot of things that have changed, particularly with respect to monoclonal antibodies being less effective, Evusheld not really protecting anymore, a return to looking at convalescent plasma. And now we're faced with the triple-demic. And before we get to our cases, we want to hear from Dr. Kristen Feibelkorn, who has graciously agreed to share with us a few slides to illustrate what's happening locally, specifically at University Health System and UT Health patients with respect to other viruses and where are we headed, variants and epidemiology. Dr. Feibelkorn, thank you for being here.
I apologize. I had to find the mute button. It changed. Hopefully you can see my slides now. I will try to keep this quick. I'm just going to give you some quick, very updated, updated to the day numbers, just to confirm a little bit of what Dr. Ponce was saying. I know he prepared his slides a little bit ago. So here are, if we look at our local numbers of cases, and this is looking longitudinally at daily COVID cases. Gray line is positivity rates. Blue is the number of tests performed, and the red part on the top is those of which are positive. You can see we've had over the summer a disconnect between positivity rate and test performed. A lot of that was at-home testing or people that were not being tested. Our positivity rate has started to creep up again. And if you look closely, here that is again. As of yesterday, our 7-day positivity rate was 14%. So it has gone back up to that. And it's actually gone up quite quickly over the past few days. I just came off of a call with DSHS, Texas Department of State Health Services, that matches what's happening in the state. And so we do definitely see indicators of a new surge happening now. This matches wastewater testing. They find wastewater testing is an early indicator of COVID spreading, especially when we don't have as much testing. Here is an increase in wastewater COVID testing. Red dots are a 15-day change of 1,000% or more found in wastewater. And see all the red dots all over the country, including here. And I've put these links in here, and for the recording, I encourage you to explore this yourself. These are our wastewater selection sites in San Antonio. I clicked on this one here. Here is where we are. So just to emphasize, really just in the past handful of days, how abruptly this has increased. This is where we are also for our positivity rate going up near vertical here. So we are definitely at the beginning of a new surge. Slightly different and updated version of what Dr. Ponce was showing. I'll just clarify, the CDC data has Nowcast involved. Nowcast is a forecast. So this version has Nowcast switched off. This is real data. Or I say real data, there's nothing wrong with Nowcast, but this is actual data ending November 19th. There's always going to be a delay because it takes time for sequencing to happen. On the left is United States data. On the right is regional data. This includes Texas. It just got lopped off. What I do want to clarify, and you'll see that on a slide later, BQ is actually a sublineage of BA.5, just to clarify. It's a bit of an alphabet soup now. It's a little confusing, but BQ is just a descendant of BA.5. But again, you do see here in the real data, BQ.1 is beginning to expand, and that matches regionally. What do we see locally? We do sequence here, and we receive specimens from Bexar County and some of them outside of Bexar County as far as where the patient lives, but collected here, funded by both Metro Health and the state. And we have a public facing dashboard, which in the interest of time, I won't show, but you're welcome to go and visit yourself. This is what our most recent data shows. It really is this confusing. I only show this so that if you get confused when you see in the media, there's a reason you're confused. The naming conventions have really evolved as all of these, as COVID continues to evolve. Once the name of an isolate has 4 digits, they give it a new letter. And so your BFs are just BA5s with lots of digits. Your BQs are BA 5.3s with too many digits, and so forth. So our BQs are supercharged BA5s. And in this most recent run, I pulled out how many of our isolates had these specific spike mutations that had significant immune escape. And you can see here, I've noted here, and you can see the BQ.1 and 1.1 have 3 and 4 of these significant mutations here. As of November 16th, we had 25.4% BQ.1 with 3, and then 22% 4. And then similar, but a little bit more updated from what Dr. Ponce showed. This is the nowcast data. This is a forecast model that the CDC has where they try to bring the data forward to the current day. It's actually quite accurate. I'm just specifying that it actually, this part is a forecast, and they are forecasting this to expand this much. And it looks like that's probably pretty accurate. And so BQ is forecasted to really replace quite a bit of the other BA5s. What about the other viruses? This is one way to look at it. This is a Syndromic Trends website, which is a website for a company, BioFire, that makes one of the tests that looks at a lot of these different viruses. And they're able to look at the data that for people who use their test to show what's circulating. I can tell you there's a lot of it out there. It's not just one thing. And we've experienced that ourselves at University Hospital. This is flu. And because we had to make the graph so high, it makes these look like small amounts, but they're not. We have a lot of parainfluenza, a lot of adenovirus. We have human metapneumovirus. We have non-SARS coronaviruses. We've seen a decent number of cases of parapertussis, Bordetella parapertussis. It seems like everything is going around right now. And with regard to flu, we did have that huge spike in October, which was very early, which Dr. Ponce noted. We're on our way down, but on our way down is still higher than we were in both 19 and 20. So on our way down, and we're still higher. So we're still, there's a reason why probably our systems are still a bit overwhelmed. So there's a lot going around right now. And so hopefully that can give you a bit of a snapshot of what's going around. I'm happy to answer any questions either now or after the presentations.
Thank you so much, Dr. Feivelkorn. Those are some remarkable data. It is very helpful to have up-to-the-minute information. And while some of us might find that extremely alarming, we should remind ourselves that being vaccinated, while it may not prevent us getting a symptomatic infection with these variants that are escaping our immune system, there is nevertheless still evidence that they're protecting us from severe outcomes and certainly from death. So we have that to be thankful for. I don't see any questions for you in the chat just yet, but I want to reiterate the open invitation to put your questions in the chat. That's how we all learn together. So I want to really take full advantage of the wonderful panelists that we have here today. And in that regard, we don't have a pediatric case, but we have pediatric questions that have come to me via colleagues who are pediatricians, and they are getting these text message questions from pediatricians. So these are some pediatric questions. And Dr. Pearson, I see you ready and receptive. Can you tell us a little bit about, is it important to be vaccinating kids? One of our questioners said, I'd like to know if they're recommending the booster in kids, especially since the newer variant has been milder in kids compared to the flu this year anyways, they say. How would you respond?
That's a great question. I think a lot of pediatricians and community members are experiencing, some vaccine fatigue, right? Or fatigue around these conversations. But the American Academy of Pediatrics still recommends fully vaccinating kids from 6 months up to adulthood. The data on the efficacy of the vaccine varies from age group to age group. In our smaller kids, we know that the vaccine prevents symptomatic infection, but we don't yet have data on preventing severe outcomes like hospitalization or death, in part because those outcomes are rare in the smallest kids. We do have some encouraging data showing that kids 5 and up, vaccination prevents MIS-C, which is one of the scariest complications of COVID for our young people. And we have real world data from the more than 1 million kids aged 6 months to 5 years who received the COVID vaccine in the first 3 months of its availability this summer. And we found that it's very safe. Just as in older kids, severe outcomes are rare. So, my recommendation is really keep having those conversations with families. It's reasonable for the vaccination decision to be based on a family's, preferences and values. And I turn to the AAP and the CDC for my updated information.
Thank you for the detailed answer. Really appreciate it. I'm going to give you a follow-on, though, to get you to talk a little bit more about how do you talk to families? How are we talking to families about vaccination when we ourselves may have lost steam on it, since much of the general public doesn't seem as concerned anymore, witness all of the syndemic stuff going on, and so many kids are in school. So what are some health literacy type strategies, Dr. Pearson, your advice for talking to families?
Yeah. So really, I think in these conversations, it's so important to figure out what the family values. I can say, as the mother of a 2-year-old who you may have seen early in this Zoom, he's home from preschool today because he has fever. I really value anything that can keep my kid in school, right? And make it easier for me to work and for my husband to do his work as well. So for us, vaccination makes sense just to reduce the incidence of symptomatic infection. Other families, they might have an immune compromised person in the family or some like a grandparent that they're really trying to protect. They might have a family member that is not open to vaccination. And they, for those families, vaccinating their kid can create part of that protective bubble around a vulnerable family or community member. So I think it's really about getting at the heart of what is important to a family and addressing the concerns that they have. If families are worried about myocarditis, for example, which can be an effect of the COVID vaccine in our older boys, I reassure them that you're much less likely to get myocarditis from the vaccine than you are from COVID infection. So, I do think it's still worth all of our time. And I know as a pediatric hospitalist, I'm seeing those surges that Dr. Feivelkorn was talking about. I know all y'all out in the community are as well. And you have to use your judgment as well about what makes the most sense, how to make the most of your time with any individual family.
Thank you. I really appreciate that input. A lot of that is applicable to our adults and families. It's not just pediatric specific advice. So lots of clinical wisdom there. Thank you, Dr. Pearson. Let's turn now to a case that was submitted to us by Dr. Cesar Garcia, who is a primary care physician. And he is unfortunately not in the group that I can see, and I hope he wasn't somebody who got locked out, but it is what it is. So I will present this case quickly and we'll get right to Dr. Markels. So Dr. Garcia tells us of a patient who is a 66-year-old woman who is resistant or reluctant to get the bivalent vaccine. So please keep scrolling down through the case for us. There is a past history of COVID-19 in the fourth quarter of 2021. There aren't currently symptoms, so the person is not sick. Let's keep going. Scroll down, please. They are vaccinated. They have several comorbids. They take a statin medication and several blood pressure medications, and they're Spanish speaking, but have a high level of health literacy. And if you could just pause for a moment on the questions, thank you so much. The concern, nope, pause on the questions. Let's go back up a little bit. Dr. Garcia's main concerns in filling out this very handy dandy and easy to fill out form. Dr. Garcia's concerns, nope, sorry. No, back down. So where Dr. Garcia's concerns were, my main, sorry, folks. Dr. Garcia's concerns are just above the questions for the echo session, just above. Dr. Garcia's concerns were about prevention misinformation. So this is a person who has a lot of comorbids, who is at risk for a bad outcome were she to get COVID-19. She's also on medications that might make it difficult for her to take Paxlovid. For instance, she's on a statin, but she's afraid to get the Omicron booster. And so how do we address the misinformation about vaccines and the importance of prevention in her case? So he specifically says the patient is declining to get the bivalent booster due to concerns about safety and effectiveness. What references can be given to address her concerns? Dr. Markels.
Hi, good afternoon. So, I mean, I think there's a lot of things to highlight, and there are some positives. This patient has already received one, has been vaccinated with the COVID vaccine. So I would highlight that. I would spend a lot of time talking about the confidence that they had in the initial vaccine, and really emphasize the same rigor that was used for subsequent, for the bivalent vaccines. And so I would highlight that although as we've been as it's been discussed, there are new variants with escape, I would still highlight that lots of real data coming from various regions have demonstrated that if you have the complete series, initial vaccination, booster, natural disease, and in addition to bivalent, you are higher, you're more protected against hospitalization and severe disease. So I would just continue to highlight that yes, there's a lot of talk about the immune escape, and that is something that we need to worry about. So I would certainly highlight other mitigation strategies, but I would really emphasize that the same rigor that was placed in the initial vaccine that this patient trusted was used in the subsequent with the bivalent vaccine, and that a portion of the component is the same vaccine. And then you're really trying to, again, address the comorbidities, really trying to understand what makes them more concerned about this vaccine than prior vaccines. Address the side effects, adverse effects that are very closely monitored to the VAERS program that really have been very infrequent as far as severe adverse effects, and less than 1% requiring visit to the hospital for side effects from the VAERS system. So again, highlighting that this is safe, that we have a lot of data, emphasize the similarities to the initial vaccine that this individual already received, and then highlight that, the limitations in treatment options because of the other medications and comorbidities, but certainly highlight that, even if not willing to get the vaccine today or continue the discussions, I always like to have follow-up appointments to continue to address, but also talk about early for symptomatic disease, early detection, early testing, and reaching out to healthcare teams so that we could provide other treatment options if available. So again, not offering other modalities just because they don't want the vaccine.
I like so many of the health literacy principles that I heard you articulate there, and not the least of which is the importance of leaving the door open. If you and the patient don't get to yes in an individual encounter, the tone and the subsequent evolution of the conversation needs to be such that the door is open, there's receptivity and positive reinforcement for the patient so that they want to come back and continue the conversation. Is there anybody in our community of learners, since this is an all teach, all learn environment, is there anybody who would like to unmute and add for us some strategies that they have found helpful when speaking to a vaccine hesitant person? You're invited to engage. Well, we do have more questions from this case, so I would like to ask our hub team to go back to this, and we landed in the right spot. Don't move that dial. We're in a good place. His second question was, the patient has a friend who is also a patient of Dr. Garcia, who believes the COVID vaccine caused him to have vasculitis. He has a concern to get the booster due to getting very sick from vasculitis. Now his symptoms are better with immunosuppressants, but he's afraid the booster will kill him. Very real fear. On a quick literature search, the vaccine has been associated with P-ANCA vasculitis. So Dr. Markels, how do we address their concerns?
So this is really challenging, and certainly I'm fortunate I haven't encountered a situation where I've seen vasculitis from the vaccine, and we've given a lot of vaccines, especially in the military. However, it has been reported, and so I think it would be really important to work with the rheumatologist and the primary specialist taking care of the patient to really try to understand the relationship. And if we understand that, we really believe that the vaccine was responsible for the onset of the vasculitis. If that's the case, I would be hesitant to give the same vaccine, especially the messenger RNA vaccine, because of if we were saying that is associated with this, because some of the cases that have been reported have had significant outcomes as far as end organ damage, kidneys, and other important organs. So I think I would really want to work with the patient to explore the diagnosis and the etiology and talk about other strategy. If we decide that this was an adverse effect from the vaccine, work with a specialist to identify other strategies for protection.
And I would agree. I've had really good experiences referring patients who had such questions to an immunologist, an allergy specialist. And we need to remind everyone that when you have the bulk of your population getting vaccinated, what are we, 75% or more, within that large population, there are some people who are going to get diagnosed with some kind of disorder, vasculitis or other, in that time frame. And the fact that they happen to get a vaccine may or may not be related. And it really can, association leads our brains to immediately imply causation, but it really does help to have the thoughtful expertise of a trained specialist to discern whether there was a plausible link or not. So thank you for that response. And finally, Dr. Garcia says the patient is fearful because 2 weeks ago, her friend got the flu shot and subsequently couldn't get out of bed due to weakness. She was diagnosed with Guillain-Barré syndrome. How do we address concerns about future vaccines when we hear about people getting Guillain-Barré from the flu vaccine? Again, I'm leaning on Dr. Markels here.
Yes, thank you. So, certainly that has been an association with the flu. And we have looked, because of a lot of concern and interest in the COVID vaccine, this has been looked at very carefully. And so far, we haven't seen any evidence that the messenger RNA vaccine, so Pfizer and Moderna, have had an increased association with Guillain-Barré compared to the baseline. So as Dr. Berger mentioned, disease happens. And so disease is going to happen when we give vaccines. And as we know, lots of infections also cause Guillain-Barré. So I think that's really important to look at. So many doses of a vaccine given a period and very carefully monitored, we did not see a higher number of Guillain-Barré compared to the baseline. There was a study published earlier this year that did look at Johnson & Janssen vaccine, and they did see a little bit of signal, nothing confirmatory yet, but they saw a signal that there perhaps could be an association. And they compared that to the Moderna and Pfizer. Again, Moderna and Pfizer really showing no signal, but they just saw increased rates compared to Moderna and Pfizer. But that is not conclusive. So again, I think when we talk about it, we have so much data. And then I love the COVID vaccine story. I love walking through it with our patients of how much collaboration has occurred to develop these impressive vaccines and how much monitoring we have. And I really do work, that's a lot of time my appointment is really working through that and the development and the science behind it. And what I do with myself, with my family, I loved seeing that, I got a memory from my son's birthday from last year that he turned 5, and the first thing we did last year was go to get the vaccine. So I love sharing that with my patients as well, because I think it helps normalize, I think it helps personalize, but that's how I would pursue this question, and that the flu is different than COVID. So I would say, because it's associated with the one vaccine doesn't mean that it's associated with another vaccine.
Excellent. Thank you for those words of wisdom that come from much real world experience in interacting with patients. I want to again invite y'all to ask questions or unmute if you have something to share. This is an all teach, all learn environment, and we are so welcoming. And we now are in a locked room, y'all. So I feel safe. Thank you, Andrea, for keeping us safe. But if I don't see questions, I do see the comments that Mia has put in. Mia has put a few links in there for us, and reminders. There are multiple reminders about filling out our REDCap survey. I guess, Dr. Feivelkorn, any closing comments about warnings from what you're seeing in the lab? Reminders?
Just to wear your masks.
Yeah, I think we saw a lot of data there that would really support the value of wearing our masks and washing our hands as this syndemic is going on. All right, this brings up to 12:59. Thank you all for your interest and participation, and I hand the microphone back over to my colleague, Dr. Raquel Romero.
Thank you very much, Dr. Bergen, and thank you so much, and Dr. Raquel, and Dr. Feivelkorn, and Dr. Pearson for sharing your wisdom with us. We always appreciate you. And thank you so much, Dr. Bergen, for the moderation and your comments in the chat. We all encourage to please add your comments in the chat. And I just would like to mention that, yeah, sharing personal experience decrease fears, right? So sometimes for something that we are not so familiar. Thank you so much for that comment. And yes, wear your mask. We all trying to keep up those advices. And again, thank you so much for joining our session today. That was an excellent discussion.